is Colonel Mark Bowyer. He's also a doctor, and he is a Ben Eisman Professor of Surgery and Surgical Director of Simulation in the Department of Surgery of USUS and the Walter Reed National Military Medical Center. He is also the chief of the Division of Trauma and Combat Surgery in the Norman M. Rich Department of Surgery of USUS in Bethesda, Maryland, and attending surgeon of trauma and acute care surgery at the Washington Hospital Center in Washington, D.C. So without further ado, Colonel Bowyer.
My name is Mark Bowyer. I'm a professor of surgery at the Uniformed Services University of the Health Sciences and the Walter Reed National Military Medical Center in Washington, D.C. I'd like to talk to you today about simulation-based training and the current and future promise and limitations of that training. I have no disclosures. My objectives are to talk to you today about what are the things that are on the horizon for simulation technology and the way to transform the way we teach and practice surgery and critical care. I want to talk also about the possibilities and limitations of the currently available simulation technology. So what are the things that are the fallacies in how we currently educate people? Well, first of all, we say that if we expose somebody to something, they master it. That written performance translates to technical performance. That if you complete a prescribed course of training, that you master the material. That proficiency is based on numbers. And that once you master skills, they do not perish. I think there's a lot of fallacies in all of these statements, and we need to do a better job. Traditional surgical education has been an apprenticeship. The see one, do one, teach one, and learning on patients. And this is something that probably should be relegated to this medieval scene as you see here. Traditional surgical education has been said that we can teach monkeys to operate. But while doing that, we need to make sure that the monkey kills as few patients as possible. Our final goal is this. We want safe, competent, and proficient surgical providers who can perform as advertised. So we can't train harder and we can't train longer. We need to train smarter, and that sounds great. So how do we train smarter? Well, we need to create a standardized, validated curriculum. We need to have proficiency-based assessment and advancement. We need to be able to identify and remediate those who don't meet the standards and help them get to the standard. We need to be able to embed technology where appropriate. And I think this is where simulation has a huge role. So simulation is not new. There are a lot of tools out there. You probably use some of them. Animals and cadavers are simulators. We have standardized patients. We have high fidelity human patient simulators, which are mannequins that talk and breathe, hooked to computers. We have part task trainers and physical models. And more recently, we're developing things called serious games, virtual reality, and augmented reality. But I think the real holy grail of this is an integrated combination of all of these tools where they make sense. And so here's some examples of part task trainers. And you can see that they range from simple things like cricothyroidotomy to a lateral campotomy for post-bulbar hematoma, and things like more complex, like the craniotomy, delivery of a baby via C-section. And here's a chest tube simulator over here as well, and a simulator for teaching how to put on a tourniquet. A number of physical models have been developed, and here you see some of these look very realistic with injuries. Here's a model with burns of a chest tube that you can put in. You can also intubate this patient. Physical model for fasciotomy. Open surgical models for doing trauma, as you see here and here. Open chest model with a beating heart that actually squirts blood out that you can actually interact with. And here you can see these very complex multi-amputation injuries that we've been seeing in recent conflicts in Iraq and Afghanistan. But the major limitations of simulators are this. They lack realism. They're highly variable in terms of their realism. They lack anatomical accuracy for the most part. A lot of these are made by engineers who get a textbook idea of anatomy. They have limited tissue properties. Most of them are made out of silicone or latex. They lack realistic bleeding and clotting, and they can be very costly. So is simulation affordable? Can we do it cheaper? Well, the real and imagined costs of simulators have been a barrier to widespread use, but they don't have to be that costly. So I like to use this example here. Which one of these two cars could you use to teach someone to drive? Well, I would argue that with a well thought out, adequate curriculum, either one of these cars could teach you the skills required to be a competent driver. And clearly, this car is going to be less costly than this one. The challenge is people get easily distracted by shiny objects. They see this beautiful Chiron here, and they think that that's what they've got to have in order to teach someone, when all they really need is something like this. And we can do a lot with low cost and a lot of homemade simulators out there. Here's some examples. Here's a chest tube simulator made very low cost. Here people are using an inner tube for bowel anastomosis. And here's a very low cost homemade hypothyroidism simulator. It's actually been shown to be just as validatable as something such as some of the physical models you saw before. I think that the future is 3D printing. 3D printing has the potential to improve the realism, the variability of the models, and also to decrease costs. Currently, the materials used to print are not that close to human tissue, but that's changing, and they're becoming more biofidelic tissues being created at a rapid pace. The nice thing about this is that you can create multiple types of anatomy. And so it can increase the variability of the simulator, because a lot of simulators just have one set of anatomy, and that gets very boring very quickly, where people learn to game the simulator. But at the end of the day, the simulators are all about curriculum. It's not the thing that's not important is it's not the simulator that's important, it's the curriculum. Simulators are just tools that help you teach your curriculum. Your purchases and choice of simulators should be driven by your curricular needs. You need to have a good process for developing and vetting new curriculum. And don't reinvent the wheel. There are a lot of smart people out there who develop some solutions, and these are available. And you need properly trained instructors. This is a key point. You need to train the trainer. Excellent clinicians don't always equal excellent teachers. The trainers are almost as important as the curriculum. And teaching with simulation requires an enhanced set of skills. You need to invest in faculty development. So let's talk about immersive environments. This is a very exciting new way of potentially training people. Serious games are taking the games, the computer games that your kids play, and giving them medical applications. And you've probably heard of virtual and augmented reality. And I want to talk a bit more about these two things and the differences between them. So what is the difference between virtual and augmented reality? Well, virtual reality, you've probably all seen these IA pieces here, which and what happens here is you put these on and all you see is what's on the screen here. Your screen becomes your world. It replaces the real world. On the other hand, augmented reality, the world becomes your screen. So you're able to see the world around you, and then you augment it and put holograms or other content within that world. And therefore, this becomes very valuable to surgeons because they can actually see the patient and then perhaps augment their reality with tools to help them do procedures. So here's some more examples of virtual reality. And there have been a number of applications that have medical and surgical applications for this. And here you see a few examples of that, where you can see people are using the virtual reality glasses and immersing themselves in an artificial environment where they're actually able to work on an artificial patient. And here you see several people working together in a team-based training on the same patient. And here's some military applications of it as well. Now, augmented reality comes in two flavors. It can be tablet or phone-based augmented reality. And this is very useful if for low-cost purposes, where you can actually replicate things underneath on the model or the physical human below and recreate or overlay anatomy or show telemetry on how to do things using a screen. And this little video here shows you an app that's on an iPhone where someone had, or it's actually a Samsung, where the app actually recognizes this design on the t-shirt and creates this anatomy based upon that, and therefore can be used to learn anatomy or to actually help dictate how to do the procedure. So the problem with this technology is if you're a surgeon, you need to have your hands. And so there are some augmented reality platforms that are hands-free. And the most well-developed ones is the HoloLens, although there are some other ones out there, such as the Magic Leap one, the Epson, and the Google Glass 2. And this has been used a fair amount recently in medical training and in surgery. And in particular, in medical training, Case Western Reserve is using it to help teach their medical students. And here you see a medical student wearing the HoloLens who is actually now learning anatomy by having holograms with a three-dimensional dissection of the body, showing the relative parts of the body and the organs and their function. And this is something that medical students can collaboratively work together on, all of them wearing HoloLenses at the same time. So there are some real-life applications of this, and here you see there's a depiction of a hologram that's actually the patient's real anatomy in a procedure where they're doing an IR procedure. And here's a surgeon who's getting ready to operate, who has populated his world here, his augmented reality with patient information, so some x-rays and EKGs and labs and things of that nature. Now, the HoloLens has a lot of potential for remote surgical mentoring. This is me wearing the HoloLens. I'm in Baltimore, Maryland, in the cadaver lab, and I'm about to do a fasciotomy on this limb. So what I've done is I am Skyping now with my assistant, who is 50 miles away, although she could be 5,000 miles away. And this is what I see. I see her in my reality is in the Skype window. And I've asked her to help me, talk me through doing a fasciotomy. And what she has done is actually loaded this hologram into my reality. And this is, she could put multiple of these, she could put videos in my reality, and she could put them I could put them 360 degrees around me. So I could put multiple ones up there. And so the other beauty of this is that this is what I'm seeing, and my assistant is actually seeing what I'm seeing, and she can actually do telestration using the tools in Skype for Windows. And here you see she's selecting the pencil, and she's using a mouse, so it's a little bit gross here, but she's now going to draw on my reality and telestrate the landmarks and show me where to make my incision or fasciotomy. So I think you can see the real potential of this augmented reality. So here is another example. This is a physical model that we were using to teach fasciotomy, and using the HoloLens, we're able to actually show underlying anatomy and where to make the incision, and use this for telemetry. And here's an example of the HoloLens again with this physical model. We've now created a hologram, and we're able to expand that hologram, show the underlying anatomy, and now we can teach people the underlying anatomy and also take them through the procedure step by step. And so what this individual is going to do is they're going to see the procedure being done on this physical, on the hologram, and then they can replicate that procedure on the physical model below. So showing where the marking goes, and then showing now making an incision. And now the individual who is doing this can now replicate that on the leg below. So in summary, simulation for training is an evolving field that incorporates numerous traditional and advanced tools and technologies. Incorporating simulation technologies into well-thought-out curricula has a great potential of revolutionizing how we train, retrain, and sustain the skills required to practice surgery and critical care. And I think that the near future, the advances in 3D printing and tissue realism, and in particular, immersive reality, will make this much more exciting and enhance this potential and will enable more widespread use in a cost-effective manner. Because at the end of the day, we want to make sure this surgeon here actually can perform as advertised and not have to read the book right then and there, and make sure that the patient has a good outcome. Thank you very much for your attention, and I hope to answer any questions that you might have at this time.